So good afternoon. My name is André Boucher. I'm from Université de Montréal, and I'm an ICRE co-chair. So I really want to thank you for joining me this afternoon as we close these 3 wonderful days where I think we heard exceptional presentations. We had paper, posters, sessions, outstanding discussions, and networking. And a lot of networking that was wonderful, I think. When I reflect on ICRE, certainly there are some words that I will recall, like technology, social media, maybe selfie, maybe tweets. But mostly, and I was discussing that with a few people around, I was really shocked and struck by some emerging paradigm shifts, like the one from moving from individual competence to collective competence. I discovered all the world of the Khan Academy, and this morning, well, I heard, and I even agreed that some kind evidence-based medicine was not always the way to go. Some provocative thoughts. So my own take-home personal message will certainly be that technology is there to help us educate for teaching, learning, assessment, and also provide better care. So lots of ideas, lots of tools, and maybe lots of solutions also. This afternoon's lecture will keep continuing in the same momentum, the same direction, since we have the privilege of having Dr. Mike Evans. So Dr. Evans is a professor of family medicine at University of Toronto. He's also a staff physician at St. Michael's, and he's a scientist from the Lee Ka-Shing Knowledge Institute. Did I say it right? Okay. Here. I suspect that there is nobody else in the room that has as many accomplishments that he has, and there are so many that I have to read them. So let's go. He delivered a baby, started a medical school for the public, written both a best-selling textbook and a children's book. He has a CBC radio show. He was a doctor at the Sochi Olympics, you know, the one where he trained. A water boy for Wendell Clark, runs a media lab, a film company, has a chair in patient engagement in University of Toronto, and has over 10 million views on YouTube. Impressive. Thank you for being there, and please welcome with me Dr. Evans.
Thanks, André. Thanks very much.
Your water is there.
Okay. Merci, André. Thanks so much for having me. It's a real honor to be here. I feel bad for you guys because you have to spend so much time with millennials, but as a baby boomer, when I came in, I had to take a picture of my car so I could remember where it was when I go back. So that may be your biggest learning point from the hour. So, so my wife's a Grand Fromage in residency education, and she's here. I won't point her out, but she's very attractive, and she's just told me not to screw it up. So that was, so I'll just focus on that. So, so I'm a doctor. I'm a family doctor at St. Mike's. We have a kind of very, I would say, a high burden of illness, complex care. And I'm definitely generous what kind of comes in the door. My major job these days is more as a maker of media. So I run a media lab, which I'll talk a little bit about, and we explain things. And then my sort of interest or my passion is probably around things that are good for a lot of things. So it could be activity, it could be the early childhood brain, it could be healthy eating, and so on and so forth. So more on the preventive front. So today I'm going to talk a little bit about how I see the landscape of patient engagement. Obviously, you guys have been talking a lot about social media. I'm going to show you some of our media that we've built. I'm going to talk about urinals. I don't think I'm talking about eHarmony, but I'm happy to talk about eHarmony. I'm going to show a little movie around end of life, talk about peer-to-peer healthcare, and think about you as a curator. But before we go any further, I just thought I'd show a quick movie. As I said, we're doing a series on best end of life. And so we went across Canada filming people And we filmed Jim out on the East Coast. And Jim's a teacher, and he had lymphoma, and he has a wife with Huntington's. And I think they've tested their kids, and something like 3 or 4 of them are testing positive for the gene. And so this is a guy who spent a lot of time with doctors in hospitals with healthcare. And so we were sort of filming about something else, but he said, can I just talk about what I want out of my doctor? So I thought that would be a good starting point for today.
If we lose that other dimension, in which is that personal person-to-person thing where you are caring for me. Caring for me. You know, think of the word, caring for me. We ask, who's caring for you? What doctor do you have? Who's caring for you? You know, but you know, if you can just push that to what it really means, the doctor comes, well, do you care for me? I know I'm demanding a lot, you know, that's the problem. I know I'm demanding a lot, but haven't we lost something significant if we lose that? And the people who have gone into that profession probably with that as their ideal. And somewhere along the line, perhaps it begins to be bleached out of the person, you know. And I think that we have to do everything we can to create the conditions in the training and the education and also in the workplace that allow those individuals who have that heart to not minimize it or mock it as incidental to the art of care. Because I think it's easy to do that. You know, we're scientists. We're about the science of care. And if you are going to live, it's because of the physics of the radiations or the chemistry of the chemo. And I haven't got time because I'm really busy trying to figure that out to save your friggin' life. And maybe he's right. Okay, do that down there then, and send me some guy in that's going to do all of that too, but is also going to sit down with me and look at me and find out about my family and find out about why I'm depressed and address those issues, not just leave it to the spiritual counselor, because oftentimes it's late at night when you're alone that nurse comes in. And you often, or I did anyways, share the depths of your soul and of your depression, your despair, your anxiety with those people, more so than your family, because you don't want to tell your family anymore, because you don't want to add to their grief. So you tell that woman that, and she says, well, that's okay, I just got to take your pulse, that's all I came in for. Okay, it has something to do with the pulse, but it has something to do with the heart. You know, can't you just stay here and listen to me? You can't solve it. I know you can't solve it, but it's the middle of the night and I've been up all night. I've been up all night listening to the sounds outside my room, watching the street light, listening to the rain against the window. I've been up all night thinking, what's going to happen to my children? What's going to happen to my wife if I die here? And now you're here in this room, and I can't tell my kids, and I can't tell the doctor. I see him for 5 minutes once a day if I'm lucky. You're here, and fate has brought us together, and this is your chance of experiencing that nobility and the sacredness, and I think that word is appropriate, the sacredness of being a caregiver. You know, this is what you came into this for, to attend to me. What a marvelous opportunity, I think. How many of us have that opportunity? How many of us go through mundane jobs over and over again? And here you have that opportunity, even when they're dying, even when it seems like you failed. I'm dying, you know?
Yeah, so he's so thoughtful and sort of reminds us of, you know, why we're in the game. Do you know what I mean? And I find myself staring at the EHR and not looking at my patient. And Jim, you know, just reminds us, you know, A, of that, and B, of what good fortune we have. And, you know, I think probably this conference has been a lot about how the landscape of healthcare is changing. But I think in a lot of ways, it's not changing. It's still about relationships. Relationships trump technology. If it's a technology that makes my relationship better with my patient, then you're cooking with gas. So And I'm going to talk a little bit about that. But I always sort of love that, that healthcare totally is changing, and it's totally not. This is a classic from Larry Green. So, I work in a big academic hospital like many of you. 1 in 1,000 comes in there. Maybe 1 in 3 comes into primary care, so family doc, nurse practitioner, pharmacist, et cetera. But 2/3 of healthcare problems are actually solved at home. And when we think about sort of innovating the healthcare system, I think a lot of, some people in the public would say it's all about having a fancier machine in the hospital, and certainly those are necessary. But I think for the big opportunities, it's about where the care is happening, and that's not in our clinics. And I still don't understand why, a lot of, say, diabetes care isn't happening at the YMCA. Why they come see me 2 or 3 times a year, and they're seeing them 2 or 3 times a week. So I think we have to think about where care is provided, and certainly, if you look at some of the pieces here, so, when I'm seeing patients, the trial data on sleeping pills, the systematic review maybe added 20, 25 minutes in Karen Glass's review for people over 60. The CBT trials of head-to-head show it's much more effective. And so I prescribe Sleepio or whatever your local CBT is online. I run a little email clinic, and what's interesting is, and I actually started because an 87-year-old said, my husband's got Alzheimer's, can you just email me? And you can't say no to an 87-year-old. And so, and what's interesting is, if I see somebody with a chronic disease, and I might see them 6 times a year last year, this year I see them 3 times a year, but I'm emailing them, 7 or 8 times. And our relationship is actually better. It's more timely. It's sort of interesting. Remote monitoring, would be the classic. So 1% of our population takes up 50% of the cost, 5%, 84% of the cost. Why we aren't sort of plunking in some remote monitoring there and thinking about that. So lots of opportunities, but certainly our clinics are ready to be blown up, and we're the biggest kind of resistance. We're the biggest problem because we're set in our ways there. So this is just to say most patient engagement is sort of aimed at this person. So this person is amalgamation of all the people around the outside. But you guys know that this person and this person and this person and this person all have different ways of understanding, different levers for change, different literacy levels. And so this is going to be the future of many of our offerings will be how can we help them customize to one another, and how can we make it a personalized experience. So I just wanted to give you, I know a big theme here has been social media, so I just wanted to give you 3 kind of case studies that I've been sort of running into lately. So this is kind of famous and eccentric, like he's one of those billionaires that people, he's kind of richy rich, that people don't like. They find him like he's ostentatious and driving around in his Bentley. And so he proclaimed that he wanted to be buried with his Bentley like a pharaoh. And so he did this big dig in his backyard, and all the Brazilian radio stations and TV stations all tuned in. And I know there's some Brazilians here nodding. And then on the day of the announcement, he actually said, I'm actually not going to bury my car. You guys all thought it was absurd. Absurd is what people do every day when they bury their healthy organs. And so he turned 6 Facebook posts into, I think it's 172 million social media imprint. If he all the ads, all the film and TV and news time he had would have cost him $22 million. It cost him, what it cost to dig a hole in his backyard. And most importantly, in the 1 month after the event, organ donation went up by 31.5%. So just such a there's so many opportunities like that to kind of just flip things. This would be a more boring class example. This is a patient who was in seeing her niece. She couldn't see her family doctor for 3 days. Her niece was diagnosed with Hodgkin's, and and she just sends me this picture. She'd been bit by a bee, as you can see here, and then she developed secondary cellulitis. She wouldn't have gone in for 2 days. And it's just a simple thing. Why can't we just be treating that and phoning in the prescription and so on and so forth? So, and then this is sort of an interesting one. So those of you that are Canadian would recognize Don Lowe. So this is sort of a famous thing. And so Don's wife came to me just before he was dying. We were doing this series on end of life. And Don said, can you film me? And he had this horrible brain tumor. It hurt him to listen to people. It hurt him to speak. He just wanted to take a milkshake and die. He wanted physician-assisted death, which we don't have so much here in Canada. And not everybody here in this room would think that's a good thing. And I'm not sure you know till you're in the moment, to be honest. But so he's in the moment. He's a thoughtful guy. He guided us through SARS. And so we just taped them. We didn't think anything about it. We just taped them. We put it online. And, in a week, we had sort of 80,000 views online. CBC had whipped it up. And, but maybe sort of most interestingly, it had gone from nowhere to being talked about at the National Health Ministry's meeting, and it was sort of front of mind for them. So I think to have something go from zero to being frontline at the ministry's meeting in 10 days, anybody who's done sort of public policy knows that it's a real challenge. So this is another future look. I've been doing quite a bit with Apple lately out in Cupertino. And so they make you sign all these sort of NDAs, so you can't get into all the details. Not that I know that much. They kind of keep you in cells. You sort of walk into a room and they have all these people there, and they pelter you with questions. And most of the doctors they're working with are anesthetists, sort of body metric people. And but their future is, so if Jason has hypertension, which I'm not sure if he does, he would, and I would see him 2 or 3 times a year. In the future, I'll be prescribing him an app. The app will be monitoring him on his Apple Watch. It'll data visualize it back. If he wants to share it with some people with high blood pressure in his hockey team, or if a woman wants to share it with her book club, or what I call a wine club, they can sort of interestingly sort of watch it and be competitive about it and look at it. Or he may just say, no, I just want, what we would call audit and feedback. I just want to see where everybody else is at. They'll drop in one of our whiteboards on high blood pressure, which we haven't actually built yet. And then Siri will actually say, Jason, you got to move more. You're sitting too much in conferences all day long. You got to, and it'll come on in a Jewish mother's voice or a Scottish mother's voice, whatever works for Jason. So you can see that this is this incredible opportunity, because I'm only seeing him twice a year about his high blood pressure 3 times, whereas this is Siri seeing him every day. And these are the opportunities, little nudges throughout our day. So it's so interesting. And you can see how it's going to crash as we give people too much information or too little information, and we're not going to get it right. But you can see how it'll come around in the end. I just wanted you to think a little bit about innovation. And so for me, at least, the biggest kind of leap has been being with creative people. So filmmakers and designers and illustrators. So my point here is that when you're thinking of building interventions, to just enlarge your team beyond doctors and nurses and people on one side of that ethnography, and think about just blowing out your team a little bit when you're thinking about interventions, because that's been huge for us. Another thing is just a sort of attitudinal thing. So one of my friends, he's a family doctor out in Edmonton, I think, and he was running a sort of educational thing around sexually transmitted infections with the community, and he had in his teenager, or somebody else's teenager, to staple the condoms onto the backboard, and this guy the kid stapled like 400 of the condoms on there. and thereby affecting their community effectiveness. And so he laughs, and of course it turned into a hilarious thing, and it was their like most effective public educational thing. And everybody got to take home one of these staple condoms. And so we have the sign in our lab, and just to remind us that, often in these sort of failures, you see opportunity. A lot of our work, so, I work in a clinic, SA Mike's, it's, a lot of high burden of illness, shut-in patients, pretty marginalized. And so I'll say, oh, let's do this. And somebody will say, oh, that's never going to work with my teenager or my shut-in or whatever. And I'm like, you're right, but let's just roll something out, what they call in the high-tech business MVP, so minimum viable product. And so think about if you're a obstetrics doer or a pediatrician or an endocrinologist, what would be your little thing that you're doing all day long that you could do a lot better? What would be your little tweak, your minimum viable product? And in fact, we do this project with the IHI in Boston where to kind of get that theme of making quick change, we have something called the 90-day project. So we take a kind of killer health problem, so I don't know, falls in seniors, and we do a kind of search, evidence-based search. More, we kind of reach out to grand fromages in the area, and we sort of build this little intervention. We drop it into clinic, we measure it, and we have to do all this in 90 days. So our failure rate is about 60%. But when you do that, at the end of the 90 days, you're like, exactly, my metric was too crazy, it wasn't nurse friendly, it wasn't patient friendly, I did too much, I did too little. And so I get you to think about just putting a little time frame on that, because we have all been involved in interventions, because clinicians and doctors are the worst. It all has to be perfect before they roll it out. And it's never what you think is the kind of home run. Like with our 23 and a half hours, which has about 4.5 million views, I started with hockey cards. This only makes sense to a portion of the audience. Hockey cards for pharmacy handouts. So you go in and get your metformin, and the information would come on a little hockey card. And so I thought it was the greatest idea ever, and it was a total failure. The seniors thought it was too jokey joke. The teenagers with asthma thought it was great, and otherwise it was a bust. Then we did a kind of, but I got introduced to our illustrator, and then we did a kind of low literacy comic book for women with breast cancer and one on prediabetes, and that was a base hit. And then I said, hey, can you just draw while I'm talking? And then he said, well, what topic are you going to do? And if I was coming from medicine, I would have said, oh, let's do it on diabetes, or let's do it on, headache. He's like, no, I don't really care about that. I'm like, what's the most important thing I can do for my health? Do you see what I'm saying? So that's the patient perspective, and that's what we did, and that's, I think, what drove some of that. So in our lab, our motto is we suck less, Incorporated. So we try and put something out that sucks a little less, and go from there. The next thing I'd like you to think about is we spend a lot of time thinking about what's the matter with our patients and so on and so forth. And I do think we have to spend a little bit more time thinking about what matters. So this is always the case with patients, especially with complex problems, where we're, pushing our, blood sugar control and our 80-year-olds and our hypertension and we don't want to give up on them, but what matters to them is completely different than what we're focused on. And I think that's true for a lot of things. And so I get you to kind of think about that when you're thinking about changing your practice is, what's the matter here? What's the matter with our system? What's the matter with my patient? But also, what really matters? And, for me, a big part of that is I don't understand, like I just had a resident, a medical student with me for last year, and she went through all her rotations and wasn't taught to prescribe exercise once. Like when we look at the cascade of health, having good social capital and good relationships and eating well and exercising, we aren't teaching our residents how to do that. Show me the resident who's a fantastic teacher of how to eat properly. And so this is sort of an interesting thing for me. So if you look at this trial that just came out last month, it's in men. 20,000, albeit a cohort study, following men that had heart attacks. And they did the 5 healthy things. So it's stopping smoking, drinking less, eating well, being active, having a lower waist circumference. So how much do you think that affected their heart attack rate? 80%. How many people do you think actually did it? 1%. So I just sort of think sometimes we have to step back a little bit and think about where we're going with this as we spend all our time focused on very siloed medicine. So this is the trial, and so I think all these things are good. And then just moving people, our obsession with 6-packs and saying, look, I just want your 1-pack under 37.5 inches. That's all I'm shooting for here. But, you know, like I tweeted this and said, new treatment from Sweden reduces heart attacks by 80%. So, and this is just a second sort of mind tilter a little bit. So when we look at data, I have a lot of obese patients that are active. And I'm not saying I don't want them to lose weight. There's lots of data showing that if they can lose weight, there's all sorts of better outcomes. But if you give me a choice between a skinny sedentary and an obese active person, I'll take the obese active person any day of the week. And I just, again, sort of like thinking about what matters most. If I was the health minister, I'd be pushing activity, not weight loss. And, you know, also show me the fantastic randomized control trials of weight loss being effective. So just to think a little bit about what we're shooting for here. I'm more interested in the cascade, but something to think about. So again, when we're thinking about our patients, I'm interested in them being active. I'm interested in their outlook and how they problem solve and their resilience. And I'm going to talk a little bit, or I'm just going to show a little bit of a movie on tweaking habits. So this movie is called Make Your Day Harder. I put it out actually after I did a radio show on erectile dysfunction. It's not about erectile dysfunction, but we got many hits that week. So clearly we have to put one out on erectile dysfunction. And I shouldn't have the word microchange and erectile dysfunction on the same slide. But anyways, so this is just about your week and about sort of thinking about our little sort of nudges in our life, you know, often around technology, you know, but it's also about the brown muffin. The brown muffin is high fiber and it is whole wheat compared to the white one. It is better, but they should have a sign that says, you know, you have to walk for 45 minutes to walk off this bad boy. You know, so we don't have, we have to think a little bit about our nudges. So anyways, here you go.
Hi, I'm Dr. Mike Evans. Usually I'm talking about the science behind best health, but today I want to start a movement called Let's Make Our Day Harder. I know that sounds counterintuitive. In fact, usually I'm asking, how can I make it easier to do the right thing? But let me explain. A recent review in JAMA Internal Medicine compared the health of baby boomers to previous generations. It showed what you might expect. Medical advances have led to longer life expectancies. But it also shows something else. U.S. baby boomers have more chronic disease, more obesity, and lower self-rated health than members of the previous generation at the same age, even though we smoke less and work out more than the Mad Men generation. So what's the difference? Well, I think for a variety of reasons that include technology, culture, and attitudes, we have a severe generational case of sitting disease. We watch phones, tablets, and TVs. We stare at computers while we work and pride ourselves on not moving for 4 hours straight. We don't walk to a friend's house or a coworker's office. We text them. I text my kids in my own house. Don't get me wrong, I love technology. There's lots of good to be had, but I also think we need to be mindful that as technology becomes more ubiquitous, it can loot the medicine chest of our single best treatment for good health, being active, moving. We shop on the internet instead of walking to the store. We have vacuums that automatically circulate so we don't have to. Electric toothbrushes so we don't have to move our hands up and down. With the push of a button, we can manipulate the TV, the music, the temperature. We might even choose our house based on these conveniences or on the size of the TV room or garage, not walkability. Living further away gets you a bigger house, but it can also mean another half-hour day of sitting in your car. To compare ourselves to the recent low-tech, simpler past, let's look at the Amish. The average Amish dude walks 18,000 steps a day. The average Amish woman, 15,000. American men walk 7,200 steps a day and women 5,200. In Canada, we're a bit better, and I actually find these numbers a bit high, but 2009 data show 9,500 steps per day for men and 8,400 for women. Unfortunately, this drops by about 1,500 steps a day once we hit 60. I think it's time to change our prevailing attitude. Maybe easier isn't really better after all. So how's about you and I start a movement, an anti-pushing the button so the door opens automatically for us movement? I'm not talking about extra stuff like going to the gym or running. If you do that, it's great. I'm talking about the health goal of our daily habits, what I call tweak the week. It's about looking at your week and seeing where you can make it harder by taking the stairs or riding your bike or getting off a stop early on your daily commute. Have a walking meeting instead of sitting in a conference room. I had a 90-year-old patient tell me the other day that he gets off 2 floors above his floor. When I asked him why, he said, well, I can't go up the stairs too well anymore, but I can still go down. Can you flip technology and use your phone or other wearable to monitor and remind you to move or stand more? How about going for a walk at lunch instead of just going somewhere else to sit? Can you reframe buying a push mower or a rake or a snow shovel as an opportunity? Instead of driving around the parking lot for 10 minutes trying to find that spot that's 10 feet closer, can you just park farther away in that spot reserved for people who want to live longer and have a higher quality of life? Let's rethink this a bit. Let's you and I and our loved ones and our coworkers and our friends, let's all mix in a little low-tech into our high-tech. Let's do something that's totally in our control. Let's make our day harder.
That's it. Woo! Yeah, I sent that to a friend, and she was just ordering something where she can lie in her bed and open and close her blinds. She's like, oh, now I can't order that thing. Oh, my God. So now I'm just going to talk a little bit about what we call peer-to-peer healthcare. So peer-to-peer healthcare is, I guess my thing is, I think the biggest healthcare workforce out there that we don't kind of take advantage of is patients. And so I'm going to talk a little bit about how we kind of take advantage of that. So in our lab, we, as I said, kind of combine the clinician researchers, the people, and creatives. And we do, with this sort of critical thinking, it takes about a month to build a whiteboard script. It's a lot of back and forth. Like we just put out one on concussions, and it was like 2 weeks trying to figure out the natural history of kids' concussions. 90% get better at 4 to 6 weeks, and there was a whole debate. Thinking about how we can make it engaging and failing, and sort of focus a little bit on the positive change. Although we're just, we're doing trials now, but we just embed ourselves in a larger trial. These are just videos that might move somebody along a stage of change. Would validate maybe some people, but it would be need to nest in a bigger thing to make a difference. And I think, but the sort of interesting thing with social media is that I used to, just hand out stuff and build stuff in the clinic. And then I ran something called a mini med school, which is a med school for the public. And I used to joke it's hard to get into mini med school, and then it's to get into med school, and we'd have like 400 people come. And I'd say, instead of seeing 25 people, I'm seeing 400. And then, we started up our YouTube channel, and we've had over 10 million people come to the site. Because we make stuff that's engaging enough. So if somebody said make your day harder, you go, this is hilarious and true, and you throw it on your Facebook channel. So trying to make stuff that's engaging, and when people kind of understand and they're engaged, it kind of creates a more fertile soil for behavior change, I think. So. And I think this is also sort of interesting. So we started out in a hospital, all sort of connected to all these things. Oh, we'll work for research.org, or, we'll get funded by the CHR. And then we sort of pulled it all out of there. So we're really, disrupting from the edges, as they say. And we just sort of sit out here, and we've had all these groups like Kaiser Permanente, massive organizations say, can you build us something? Because it's hard to build in our big organizations, and so they white label some of our stuff, and we build stuff together. We just brought together HQO, Health Quality Ontario, St. Mike's Hospital, and the Institute for Healthcare Improvement. We're just putting out one on quality improvement next month. Movember, Olympics. So we get to work with all these different players that are all interested in health, and so that's another kind of interesting story, is the kind of social entrepreneurship of it all. And then definitely in our thing is that we're, the old school kind of education would be telling people not to smoke or not to eat Scottish fast food or whatever, but or don't pour this boiling hot, coffee on your crotch. Or I know there's French people here, so sorry for blowing this, but ne prenez pas de oulala. There's German people here too. I don't know if the schnackers is an actual term, but what we've done in the past is just tell people what we know. And so stories trump data. As Adam Gopnik says from the New Yorker, no story, no sale. And so you have to storify your evidence. And I spent a lot of my life telling people, here's the data on PSA or whatever it is. So, and I think relationships trump stories. And I think your job is to build, evidence-based stories and embed them in the relationships of care, which we think of as, clinician to patient, but it's actually mostly friend to friend, loved one to loved one. And I think in a lot of ways, individuals trump organizations. Like one of the reasons for our success is because it's just me. It's just this doctor guy. It's not some big health org, faceless, whatever. And then, so I'll say in my clinic, I spend a lot of my time trying to figure out, is this viral or bacterial? I'm a family doctor. But in our design studio, we're sort of saying, okay, how can we make this more infectious? How can we make this so somebody wants to give it to another person? So, and the best Petri dish for that, for sure, is YouTube. I mean, if you look at the major 3 channels the last 60 years, 365, 24/7, it hasn't put as much content that's been put on YouTube in the last 30 days. And that's part of the problem with YouTube, is trying to figure out what's good and what's not. So we build it in the media lab. It takes us a whole day to shoot about 5 minutes. And, we got everything from concussions to smoking cessation to HPV vaccine to preparing for hip and knee surgery. We just did one early childhood brains that released at the UN General Assembly. So lots of fun in all sorts of different languages. So this guy, Renato Olivares, is a software builder out in San Francisco, and he saw 23 and a half hours, started walking every day, lost 90 pounds, built a little app that says, that you just have in your pocket. It's called human.co, and when you walk for half an hour, it goes, hey, great job. That's it. That's all it does. We were in Orange is the New Black. Who's seen Orange is the New Black? Yeah. Fantastic Netflix. It's asynchronous, meaning people watch it, and so they think it all just came out last week. So every week I get an email, you won't believe this. And I had a little bit of a hard time explaining the plot line to the nuns at St. Mike's. But this is interesting. So we allow people just pretend they're me and translate into different languages. So it's in everything from Gaelic to Hebrew to French. Although somebody pointed out the other day, not French, and Spanish. But we had a public health doctor in Riyadh translate it into Arabic, and we just put it online. And it had 800,000 views in a week. So it cost quite a bit to build the videos, but it cost like $200 to change the sound file. And we had 800,000 views in a week. I mean, that's incredible when you think about the healthy virus we could do here. Now, Ultimate Pizza Sandwich is still in first place, so we got a little work to do. So this is it, though, is that you sort of build these things and you just let them rip, and then you just see what happens. We do a lot of infographics. So this is Prabhat Jha's trial in New England Journal of Medicine, which was this 14-page article, and it basically said, if you smoke at 30 and you stop, you save 10 years. But I have a lot of patients smoking at 60 saying, I'm shot, I'm just going to keep smoking. But you're going to save 6 years of life at 60. We take text messages and kind of have fun with that. I had a design student with me for the summer, and we built a concussion infographic. So if you're thinking about building something, there's a whole bunch of build infographics by yourself. You don't have to have a designer with you, and you can build an infographic, and they're highly clicked on. I think I'm just going to skip this, and I'm just going to show another film at the end. And this is where we're going now. So we're dropping our videos into a larger, this is one on activity. And so we're doing a lot with the fuel bands. We just sort of monitor. Nike's actually moving out of the fuel band business, but whatever quantify itself, could be in your phone. And we actually drop these behavior bombs in it. A lot of reward stuff and a lot of nudge. Do you guys know much about nudge? So nudge is, it's not sort of a penalty for doing a seatbelt. It's, every grocery store is completely nudged out, so they're kind of doing little things. There's a whole science to it, so they get you to buy it. Like I went through Walmart the other day with one of the heads of Walmart, and he says, well, the pharmacy's at the back, so everybody has to go through and they'll hopefully buy something. We don't make much off the pharmacy, but all this crap around here, all these, vitamin X, we make a whole bunch of money off that, and so everything's kind of nice there. If you go to a buffet, and you put salad in front of burgers, the salad rate goes up 25%. Do you see what I mean? It's just little behavioral things. So this is the classic one. This is Schiphol Airport. How many people here are from Amsterdam? Okay, I got the whole Amsterdam section here. So this is, and then you've heard the story 17 times, but this is a urinal in the Schiphol Airport. And as I guess is a universal problem around the world, there's spillage with men's urinals. Who knew? And so, so some genius went in there and engraved a little fly in the deepest recess of the urinal. And so the men of all different cultures and ages and whatever just walk up to the urinal and try and kill the fly. And so their splash rate went down 80%. So that's like the perfect nudge. They don't even know what they're doing, right? They're just like, oh, I'm killing the fly. And yet you've changed their behavior. So, in England and the US, they're building ministries of nudge, and there's a whole Nobel Prize book about it, and so on and so forth. So building little nudges into environments are going to be big for us. So this is my last point, and it's about just the fact that, as I said, not all of you have a media lab, but all of you can curate. And you can set up a WordPress site, and I'm going to show you a Facebook site that you can set up in 20 minutes. And so this example of ours, so this is one I did on mental health. So these are the videos that I like. This one's a British guy talking about, for some reason when British people tell me what to do, I listen more. And New Harbinger has a fantastic evidence-based series on mental health that I send people to. But this is just curating. I did a thing with Indigo, which is our book, it's kind of the Barnes and Nobles of Canada. And I had these clinicians just review the books and say which ones were crap and which ones were great. And What to Expect When Expecting, which was their top-selling obstetrical book, was the lowest rated on our, when our experts reviewed, was it evidence-based? So there's this sort of disconnect what they're using. So I think a big part of your job is saying, oh, here's a new video from the CDC I like, or whatever it is. So I'm always asked, should I accept a friend request from a patient? And my answer is no. I don't like, so this is my personal Facebook. This is my daughter, who only texted me once from France, where she was there for a whole month. And she calls me homie on the text messages, and she goes, homie, what are the 3 digits on the back of your Visa card? Anyway, so that's my personal Facebook page, but I don't want my patients seeing, my drunk trip to Whistler or whatever. So you can set up a Facebook fan page in 5 minutes, and it's sort of a professional one. And I just put my medical stuff on there. So you can say the clinic's closed on Friday, or I'm at ICRE in Toronto, good luck. Or if something's interesting, you just post it there. And it'll also tell you all your analytics. So this week, I released a whiteboard on this new drink I'm releasing. I'll just blow it for you. So I pretend I'm sort of kind of snake oil salesman, and I say it's organic and gluten-free and celebrated by ancient cultures, and I go through all the Seventh-day Adventist data on reducing cardiac events and all this kind of stuff. And like people are like, oh my God, what's this drink? And of course it ends up being tap water. And so we released that this week. I just plopped it on my Facebook site, and 8.7 thousand people saw it, and 160 put it on their own Facebook page. So it's so interesting watching all this. So I'm going to show you and just end with this video. We've been doing this series with the group in England and in Cambridge and in Toronto about end of life, because as you probably know, we kind of blow it, at least in North America. Maybe the Europeans have got it all figured out. But and so this is just a video of a guy in England, and he's he's dying, and he's off the charts reframing the experience. And I wouldn't expect everybody to be like this or all my patients to be like this, but I just want you to think a little bit about how one little piece of media could sort of change your perspective a little bit. I'll let it rip.
In 6 weeks' time, I will be dead. I will be cremated. I will face huge fear. But it is an extraordinary experience. This is the most exciting and the most extraordinary journey of my life. My only regret is it ends. I'd like to be on this journey with you almost forever and a day.
I was asked to shoot an intimate portrait of a man that I didn't know. I knew that he was very ill, but I really wasn't sure what to expect.
It's only when they say, Philip Gould, you're going to die, get used to it, and this is going to happen in weeks or months. It's only when that happens you're aware of death. And only when that happens also that suddenly life screams at you in its intensity. I saw my children born, I saw them born, and I saw the incredible, massive potential of that moment. And when my father died and the air left his body, it was as powerful as the air entering the body of my daughters. And I knew that the purpose here now was to give as much love as I could to people who mattered to me, even though I was dying. And my life became death. It gained a kind of quality and a power it had never had before. It entered a new zone, which was the death zone.
Oh, sorry, it's my wife. Just 1 second. Hi, darling. Yeah, you okay with all this then, darling? It's lovely. I feel good. It's going to be beautiful there. I'm going to love it.
After an intense, intimate discussion, Philip and I decided to shoot his portrait at Highgate Cemetery on his own grave.
Only when you accept death can you free yourself from it, can you deal with it, can you move forward from it. So acceptance is the absolute key. At that moment, you gain freedom, and you gain power, and you gain courage. This is it. This is going to be, my home for eternity. I do really feel, in my mind, I've reframed it, I've changed it. It's not some gloomy, ghastly thing. It's this, I just think this is such a wonderful, wonderful idea, the community of the living and the dead. And I have no fear at all about going to this.
It's great.
I'm happy about it. I feel a sense, actually, almost of optimism about it, of almost looking forward to it as the next stage, and certainly very, very comfortable. You sort of think, God, I'm scared, I'm a coward. I thought I was a coward. I was the kind of guy who was too frightened to kind of go too fast on a bike in the evening time. You think, I can't do this, I can't do chemotherapy, it's too painful, it's too horrible. But you do it. And then they say, by the way, mate, you're not going to have a stomach. And you'll never eat normally again, ever again. And you kind of get used to it. And then you sort of think, actually, every single thing I throw at you is handleable. You can do it. I have my wife and my children there for me at this moment because I am defining myself now through death. I'm giving meaning to myself through death. Without that, I do not know what I would do. I rely upon them enormously, almost completely. I try and lead them. I try and inspire them. I try and show strength. I had a couple of really tough nights. My breathing was bad, my coughing was bad, everything was bad, and Gail was in a bad state too. And then I just lay there and thought, okay, this is bad, but this is death. And as long as I look death in the eye, and as long as I accept that I can choose the death that I seek and the death that I choose, I have some freedom here. I have some power here. I have some possibility to shape for myself my own death. And at that moment, I have a kind of freedom. I've had more moments of happiness in the last 5 months than perhaps the last few years. More moments of a kind of private ecstasy than really for many years, when I just feel at one with the world. The thing I'd like to say to my daughters is, I love them. And the thing I'd like to say to my wife is, I'm sorry I let you down, but my God, you're fantastic. And I'm not letting you down now. And you will have the best life afterwards, I believe. I love them all. That's what I want to say to them.
Yeah. So very powerful and very, I don't know, I visited a woman today. She's not a patient, she's a friend, and she had thymic cancer and just had her chest tubes taken out, very kind of rough situation. And you know, just the wisdom, she has a daughter same age as our daughter, and just the thoughtfulness that these people have is something we should be capturing and understanding and sharing with one another. So I think, like he was sort of saying there in a way, don't let what you can't do prevent you what you can do. And I'd ask you to think a little bit about you know, start something small. Just let go of perfection a bit. You know, it's like we do with patients. You know, the 80-20 rule. Hey, we're not looking for perfection. We're looking for consistency. And just to try something simpler, make your day a little bit harder. We've got some new projects coming up. One's called Beer League Doctor, which will only make sense to Canadians, maybe some people from the Eastern Seaboard. We're doing a whole series on eating well, which is fascinating and complicated and tricky and crazy. And then we're doing something called the Better Life Experiment. So this is just doing it with YMCA, just looking at sleeping, eating, being active, having good social capital, and thinking well. So I feel like these things get lost, and so we're going to build a program that's just around things that are good for a lot of things. So it should be fun. So that is it. I thank you very much for your time. If you want to see any of the YouTube channel, you can take any of those videos and embed them on your own channel and take credit for it. If you want to see more of the kind of peer-to-peer stuff, if you Google The Truth of It, we did a series, we interviewed about 50 Canadians with cancer around their illness, and very interesting findings. So if you Google The Truth of It, you'll see that. And then, yeah, if you want the updates, you can just see on Twitter and Facebook, and we're doing a crowdfunding campaign for non-silo stuff in health. So I'm going to shut up and take some questions. Yeah, thank you very much.
Thank you very much for this very inspiring talk. You know, you remind us that among all the occupations that we have, the most important responsibility is not only to treat, but to care. And this is very important as a message. Maybe we have time for one question?
Just one.
Yeah. Okay, there's somebody there.
The professional Facebook channel, how do you do that?
Yeah, so if you go onto Facebook, it'll give you options, and you can just click on, so it'll say, you know, Facebook personal, Facebook business or professional, and it's all from there. It gives you a whole different set of analytics than, I don't really remember analytics in my normal Facebook channel. And then I don't know if you saw it, so it's a business proposition for them because they want you to click, I've never done it actually, but they want you to click on the boost post thing. And they have this sort of price thing that comes up and say, for $174, we can send this to 10,000 more people. So it's kind of interesting. But if you just go to the Facebook site as if you're logging onto a new Facebook thing. So, and then when my Facebook comes up, it says, do you want the Mike Evans channel or the Dr. Mike Evans channel? And then I just kind of flip back and forth. I don't love Facebook. Like I only go to it once every 2 or 3 weeks or something. I don't really care what my old friends are doing. So, but I must say I like Twitter. If I was to pick, I know people are anxious about these things, but Twitter you can check once every week or once every month or once every day. If you're interested in boat building or endocrinology or whatever, you can just follow people you're interested in, people that inspire you. And it's quite helpful to kind of keep up to date in whatever you're kind of interested in. So,
do you think that as patients become more informed through all the technology, they will challenge more the doctors for their own care plan of care?
Yeah. So, I mean, you know, I think the answer's yes. I guess. You know, it's this sort of feeling like they're in the best place. And I think technology allows them to see that. I think there's a whole bunch of negative sub-stories. So people on Dr. Google pre-diagnosing themselves. You know, when we look at the cancer literature, which you probably know, they put them in blockers and monitors. So my dad would be a blocker. He would want to talk to 2 or 3 people, that's it, trust his clinician implicitly. My stepmother would go on the 1-800 site, would go on the web, but when both of those groups become stressed, the blocker doesn't want to hear anything more. The monitor is on their 800th website looking for, you know, emu hair from Morocco. So I think there's some negatives, but overall, I'm a huge fan because I do feel like people can get to where they want to be, and I think our relationship will be different that way. I think you'll see a lot more kind of coaching stuff and preventive stuff. And so I think again, if we sort of focus on that relationship, things will get a lot better. But I just think people have to be mindful of the, you know, we're going to crash. It's this constant usability game. And, but I think it'll slowly get better and better and better. And people have different experiences. And, you know, we have a kid with Hodgkin's. She goes online, says she has Hodgkin's, and she had 650 more friends that afternoon. And our brains are sort of thinking about, is that a good thing or a bad thing? But it'll be interesting to watching communities rally around people. And the new evolving group is sharers, you know, people who want to share their experience. So.
Many thanks again.
Thank you very much.
Dr. Emery.
You don't get to leave.
What?
You don't get to leave.
Okay.
Merci beaucoup, André. Thanks very much, Mike, for a dynamic and provocative closing plenary. You get to stay up here. Over the past couple of days, we've explored many facets of education in the digital age. Your presentation highlighted the importance of considering the perspectives of our patients and being aware of the place of technology in their lives now and in the future. The insights you provided this afternoon at the intersection of healthcare and technology have been eye-opening. Just looking at the flurry of comments on Twitter made me certain that you've stimulated reflection on this topic that will continue and that will follow us on our travels home, making this a most fitting closing plenary lecture. You definitely sucked less. With this in mind, it's my great pleasure to present you with a certificate in recognition of your most enjoyable lecture.
I thought you were giving me the iPad.
So yeah,
Oh, okay.
nice one. Ladies and gentlemen, thank you. Joe, please join me in thanking Dr. Mike Evans.
Thank you.
I think we
Well, thanks, Kevin.
are supposed to get a photograph. Perfect.
Thanks.
Thank you so much.
Thanks, man. I'm going to close up here.
All right. Mike Evans, you're so inspiring. You're like the health advocate. I'm inspired. So, hi everybody. This is our chance to say goodbye. There's a couple more events this weekend. There's the International Resident Leadership Summit continues on into tomorrow. There is a very special dinner tonight. You get to meet Vincent Lam and recognize some award winners. I wanted to do just a couple of things. Some of you might have been asking me why is conference chair and occasionally seem somewhat intelligent, do I walk around with so many like badges and labels on here and ribbons? Well, I want you to meet my, my very close friend and colleague. Can I have the next slide? This was like perfectly seamless in the practice. I'm telling you, it was like perfect. Oh, no, it's after this whole sequence. Hey, we'll come back to this. Come back to this. Uh-huh. Uh-huh. It's a little bit slow. There. My close friend, Linda Snell. Brain the size of a planet. Practically my sister. I talk to her so much. And every year at ICRE as fellow co-chairs, she comes up to me on the first day and says, Jason, look at my ribbons. Keep up, buddy. And so I scramble. I go to like every booth. I ask the staff. I say, come on, I'm chair. You can give me an extra ribbon. And so, Linda, this is for you. There you go. And the last one I got off John Sherbino, the co-chair. He said, I should have a badge for a mediocre hockey player. All right. So sorry about that sequence. Let's just go back up. All the way back. Uh-huh, uh-huh. This was so smooth in the practice. Okay, can you rewind that for me, guys? Okay. So ICRE 2014 is almost done. I hope you're as inspired as we were. At the beginning of this, I encourage you to find one new friend, an idea. Honestly. Work with me, guys. Yes. Okay, one new friend, one new idea, and maybe one new project or initiative. And we've had some really inspiring sessions. I hope you found something that really resonated with you and you thought that this conference brought value for your time. I know you're extremely busy. We had the program administrators and they were very excited about some of the changes coming down. We had really intelligent conversations about some aspects of medical education. We had some great plenary speakers. I'm going to tell you a little bit more about that in a second, that I think changed our view. We had Key Lime Live with green shag carpet. That was a new thing for ICRE 2014. We may do it again, just so you know. We had the back of Jonathan Sherbino's head, which was prominently featured at the SOMI Summit. So this is the social media summit that was held a couple of days ago. It's the first time we put all these people in a room. We think about digital media, like Mike Evans, and medical education. And it was a really magical thing. I was really glad I could be a part of it. Some of you are across the city at the International Medical Education Leaders Forum. And that's where all the presidents and CEO talk about system issues. And some of you are at a leadership summit in another part of the city talking about how can we develop leadership competencies for physicians. And still others were in surveyor workshops and new program director workshops and so on. It's been a dynamic conference and there's been a lot going on. All right, we had great plenary speakers, didn't we? I do feel inspired. I've been inspired by Lorelei Lingard to change my view of competence. You know, I've talked to Lorelei about that topic for almost a decade. Her work's been building up to that talk. But she hit it so clearly, right on the nail, and it really was a paradigm shift for my brain, at least. I hope it was for yours. Rishi Desai introduced to us the Khan Academy and the whole beautiful story of flipping the classroom, something that started so simply, so innocently, and became so powerful, and is now a real freight train moving through education in general. Now I'm thinking, as an educator, how am I going to implement that in residence education that's around me? And should I? Mike Evans, I mean, how inspiring a talk. It's so powerful because all these things that Mike's thinking about and considering are really so patient-centered and have the ability to make such an impact. I'm truly inspired. And I'm ending with the Jalali Cook brawl, because I just thought that was such a wonderful contrast between two great educators who came at a topic with two different perspectives. I hope you found all of these really useful for you. At lunchtime, we had our program advisory board meeting, and we decided to book another debate next year. So we're open to your ideas. If you have a great debate that you'd like to hear, one of the topics nominated was milestones versus EPAs, duking it out to the death. We'll think about it. So lots of great sessions. This is just a few bullets that the team selected. Program director survival stories. There's so many great sessions, and like you, I wish I could have been in more of them. I hope you found something for you that changed your practice, changed how you think about medical education, and that's what this conference aims for. We aim for impact. Ali Jalali has brought us what he thinks are the top tweets of the conference. So we had more than 8,000 tweets as of about noon today, and our imprint on social media is over 17 million, almost 18 million impressions, which is an enormous impact for a conference. And in fact, in Twitter Canada, we were trending in the top 3 hashtags today, ICRE 2014. So this really was a digital conference, or at least a conference in the digital age. Here's the top tweet so you can look for your face. How many of you picked up Twitter for the first time at this conference, like really use it for the first time? That's so cool. That's so cool. Cool for you. All right, so I have some winners for you. This is part of my closing job. Ready? Drum roll. Okay, first I'm going to do a little bit random order. So the iPad winners, don't come running down the aisle. This is not like the Oscars. The iPad winners, you actually have to go to the reg desk with photo ID. Why we're asking that, I'm not sure, but it's probably related to a previous incident. That's all I'm saying. So, Dolores McKean from Dalhousie and Lynn Sonnenberg from Alberta. You just won an iPad. Way to go. Top ICRE poster, Dr. Curtis Boyington. Are you here, Dr. Curtis Boyington? Nope. Okay, we have a lovely gift for you, which I'll now give to somebody else. I'm just joking, we'll mail it. Okay, What Works paper, Miss Joan Benendek. Miss Joan Benendek? Not What Works paper? No, okay. 0 for 2. Royal College Top Resident Paper Award, Dr. Ningsi Sun from McGill. Dr. Sun? We're all cheering as somebody's leaving. Bye. Okay, last one. All right, so we can get this person. The Royal College Journal of Graduate Medical Education Top Research and Residency Education Paper Award. This is like our biggest award for the whole conference. Ready? Ready? Dr. Linfa Stroud from the University of Toronto. Is she here? Okay, I think I nailed all those. Is that right? Okay, so that was 2014. Here's Vancouver. Isn't it a beautiful city? No, that's not Sydney Harbor. That's not the Opera House. It's Vancouver. And so Vancouver, Canada next year, about this time, is ICRE 2015, and we want you there. The theme is Residency Rediscovered, Transforming Training for Modern Care. That's what the planning board has selected. And we're going to feature at this conference a whole bunch of things that you like. PD survival stories, resident survival stories, a little bit of how-to for technology. I'm signing up for the Facebook one. But the major component that goes with the theme will be a whole bunch of examples of people who've done radical changes to implement residency education from around the world. That's our goal. We're going to go select those people. We've already picked a couple of our plenary speakers. More about that in the coming months. But please come and join us. Please book and please bring a friend to Vancouver, ICRE 2015. It'll also be the launch of the Royal College's official CanMeds 2015 framework and all of the materials that go with that for you to implement. Okay, tell us how we did. Please fill out the evaluations for the conference. You can win things. You can be part of our montage that we'll put on the web. If you tweet yourself a little picture and a comment or a little selfie video that says, come to ICRE, we'll feature you on our website. You'll increase your digital footprint. So post-conference events. Tonight, International Residency Education Awards Dinner, Vincent Lam. Physician as Wine Lover is on right now at the Intercon if you take the bus over. And meet our sommelier from the Royal College, some Canadian wines, very nice Canadian wines, and Linda Snell, our physician sommelier. IRLS is ongoing. I mentioned that. I just want to mention to you something called IceNet. How many of you have ever heard of IceNet before, by show of hands? Oh, a few people. Okay. Thank you, those 3 people. International Clinician Educators Network are for people like us who spend a lot of our daylight hours thinking about clinical education at various levels and then also have an experience in clinical medicine. This is the network for you. So in some countries, there's no such title as clinician educator, but this is kind of like a self-help group for all of us. And this series of meetings is usually a one-day event. Tomorrow it's on Sunday at the Intercon Hotel. And it's a very, very different kind of conference. So we have a series of all-star speakers. They stand up and they give a proposition which is very, very provocative. The very first speaker we had was the famous Ole Tankate from the Netherlands. And he stood up and he began our series by saying, it's the end of medical school as you know it. Discuss, sort of thing. So if you want to be a part of that, I can tell you it's the best conference I've been a part of, are these IceNet series, for my own learning. So I encourage you to attend. It's tomorrow, Sunday morning at the Intercon. You can register at the door. It's not expensive. Complete your evaluations. You can win a $100 gift certificate. And we'll see you in Vancouver. Thanks so much for coming to ICRE.